Welcome to Louisville Lectures, PEM Little Lectures.
Hi everyone, my name is Liz Lehto, and today we're going to talk about interpreting lateral cervical spine x-rays. The reason we're focusing on the lateral view is because this is the view we get in our trauma bay for our trauma stats, and it's important to be able to quickly interpret these at the bedside. So we're going to review a few quick pearls. First, let's talk about cervical spine injury. 72% of spinal injuries in children younger than 8 occur in the cervical region. This is because children less than 8 are more susceptible to cervical spine injuries based on several differences in their anatomy compared to adults. Firstly, they have larger heads compared to the rest of their body. The fulcrum is higher. It's C2 to C3 at birth, C3 to 5 at age 8 to 12, and C5 to 6 at 12 years old and above. Facet joints are horizontal, and that can facilitate sliding of the upper cervical spine. They're more susceptible to subluxation and distraction injuries, and the spinal columns are more elastic than the spinal cord. So this is your lateral cervical spine x-ray. The cervical spine has 7 vertebrae, and the first 2 have fun names, the atlas and the axis. When reviewing any x-ray, it's important to do it the same way every time so that things aren't missed. I like the ABCDS method, which is the one we're going to go through today. A is for adequate view. We need to make sure that all 7 vertebrae are able to be seen, including the C7 to the T1 junction. This can be facilitated by pulling down on the arms to depress the shoulders. A also stands for alignment. There are 4 parallel lines that need to be assessed for smoothness. First is the anterior vertebral line, seen in blue here. It is the anterior margin of the vertebral bodies. The second is the posterior vertebral line, seen in red. And that's the posterior margin of the vertebral bodies and the anterior wall of the spinal canal. Third is the spinal laminar line, seen here in yellow, and it's along the posterior wall of the spinal canal. This line is also known as the line of Swiss-Chuck. Lastly is the posterior spinous line, seen in green here, and this goes through the tips of the spinous processes. All 4 of these lines should be nice and smooth, and disruption in any of these lines may suggest either a bony or ligament injury, as seen here. One thing to note is that in children, there can be pseudo-subluxation of the C2 to C3. This is physiologic and seen in 40% of children less than 7 years old. You can see this here looking at our red line, our posterior vertebral line. It doesn't line up like we would expect it to. Now, this can be distinguished from traumatic subluxation by looking at that yellow line, our spinal laminar or Swiss-Chuck's line. This should pass through C1 and C3, and should be less than 2 millimeters anterior to the C2 spinal laminar line. Now, if the spinal laminar line or Swiss-Chuck's line has a distance of greater than 2 millimeters, then this would be a traumatic subluxation. But if it's smooth or has less than 2 millimeter difference, then it is a pseudo-subluxation. Now, no one's going to expect you to get rulers out in the trauma bay, but if you look and see that some of the lines aren't as aligned as you would like, just make a note to review it once you're outside of the trauma bay and keep that cervical collar on. Next is B. B stands for bone. You want to inspect for normal outline of the vertebra. Subtle changes in bony density may indicate a compression fracture. On the left here, we have a normal X-ray. Here, as indicated by the arrow, there is a compression of the vertebral body. If you see this arrow down here, there is a teardrop fracture of the vertebral body. And then lastly, these arrows look at fractures of the spinous process. C is for cartilaginous space, also known as the predental space. It's the space between the odontoid peg and the anterior arch of C1. It can be seen in this image on the right by that little double arrowhead. Looking on the left here, I'm going to highlight it in red, right there. So that little tiny space right there. This should be less than 5 millimeters, under 8, and less than 3 millimeters if they're greater than 8. Increase in distance indicates disruption of the transverse ligament and or fracture of C1. And again, you won't be getting your rulers out in the trauma bay, but keep in mind that this space should be pretty tiny, and if you're concerned it looks large, just make a note to review it on the computer. Next is D. D is for discs and other spaces. Your intervertebral disc space, seen in green here, should be equal at all heights and all levels, as well as symmetric and parallel. Your facet joint spaces, seen in yellow here, should also be equidistant at all levels. And the space between the spinous processes, seen in blue here. The C1 to C2 space can be large compared to the others, and then all of the others should be similar in size. Here you can see an abnormal one on the left where there is some subtle fanning of the processes, and then obvious fanning on the right. The atlanto-occipital joint should be less than 5 millimeters. It is enlarged in the one seen on the right here by that little black arrow. Atlanto-occipital dislocation can also be associated with prevertebral swelling, seen by that white arrow here. And again, that's a normal X-ray on the left for comparison. This is usually fatal, but note that it is 5 times more common in children than adults. S is for soft tissues. The prevertebral soft tissue distance should be less than 7 millimeters from C1 to C5, which can be estimated as less than half of the vertebral body, and less than 22 millimeters below C5, which is less than the vertebral body. Enlarged spaces may be the only indication of swelling or hemorrhage from injury. Air within the soft tissue may suggest rupture of the esophagus or trachea. And do note that in children less than 2, this can appear falsely widened if it's not an inspiratory film. So here we can see one where there is enlargement in those spaces there. So that is how we go through our systematic approach to our lateral spine X-rays. Remember, A is for adequate view and alignment, B for bones, C for cartilaginous space, D is for discs and other space, and S is for soft tissue. If you want to learn more, the International Emergency Medicine Education Project has a fantastic article, How to Read C-Spine X-Rays, and that's actually where I got most of the images for this PowerPoint, and I would recommend checking on that. Thank you.